Welcome to the webinar on Living with FCS, Genetic Testing and Genetic Counseling. Our hosts for this webinar are the FCS Foundation, Ambry Genetics, and Genome Medical. Only the speaker's microphones and cameras are engaged. All other participants are muted. If you have a question, please ask it in the chat. Your questions will only be seen by the speakers and the hosts. Participants cannot see these questions that are placed in the chat. Our agenda for the webinar is a welcome and FCS overview, a session on genetic testing, another session on genetic counseling, a physician and caregiver perspective, and then Q&A. Our speakers today are Susan Toomey, a senior medical liaison with Ambry Genetics, Ashley Parrott, a genetic counselor with Genome Medical, and Fiza Javid, an MD candidate at Queen's University in Ontario, Canada. We'd like to get to know our audience today. If you would please respond to the poll in front of you. Are you a patient, a caregiver, a medical provider, or other? I'll give you a second to respond. Wonderful. We have a wonderfully diverse audience today. Thank you. Lastly, I would like to thank our FCS Foundation Board for their efforts in putting this webinar together. And we'd like to now begin with Fiza Javid.
Hey, thank you so much for having me. It's an honor to be talking about FCS today. This is a cause that's very close to my heart. And I just wanted to share that my perspective today is I'm sharing it from as an academic researcher in FCS, and as Amber shared, I'm in my third year of my medical degree, but I think most of my actual experience comes from being a caregiver to somebody who has FCS, which is my husband, as well as my sister-in-law, who both have been living with FCS since they were born. So we'll go ahead and talk a little bit about what FCS is. I know some of you might be very familiar with some of this information, but for some of you, it might be introductory. So keeping the wide variety of perspectives that we might have today in mind, then we'll go ahead and start. We can go from the first slide. Okay, so FCS in itself, so it stands for familial chylomicronemia syndrome, but sometimes you can find in research, and when you're looking up FCS, actually goes by a lot of different names, and depending on which literature you might be looking at, it was actually very commonly known as lipoprotein lipase deficiency in the beginning, when our understanding was that the disorder is primarily caused by LPL deficiency, which is true, but there are other regulators as well that can cause the disorder. So since then, we have moved on to referring to it as FCS for the most part, as well as some of these other names that you're seeing on the slide. But also if you're trying to find very old literature on the condition, there's a lot of research that uses the terminology type 1 hyperlipoproteinemia as well as hyperlipidemia type 1, which has also is not commonly used as much anymore. This is just to give you a reference if you're trying to see if you're still looking at the same disorder or disease or not, if you're trying to find information. Next slide. So the resource that I'm actually using today to talk about the basics of FCS actually comes from a very good and well done animated YouTube video that I've attached here actually, and I can put a resource in the chat as well. And the reason I really like using this particular video is because for people who might want to just explain the condition in a very short 5-minute video to somebody else, this is a very good resource to use that uses pretty simple terms to get a sense of what the condition does, what the condition is. So we'll just go ahead and talk about what is familial chylomicronemia syndrome. That's on the next slide. So FCS in general comes from familial because it tends to run in families because it is a genetic condition, and chylomicronemia because, and you would have heard the word chylomicronemia and chylomicrons a lot, when you're talking about FCS, because this is the fundamental at the molecular level, the reason why this condition causes problems, which is basically a buildup of fat carrying molecules in the blood. And the syndrome aspect of it refers to a group of symptoms that we tend to see in this medical condition, that can range anywhere from seeing that buildup of fats. Sometimes we're able to see as medical providers the fat buildup in our retinal vein called lipemia retinalis. We can also see the buildup on our skin, which is referred to as eruptive xanthomas, which you might have seen as tiny bumps that can develop when the levels are really high. Some people also get numbness and tingling. That's less common, but more commonly things like fatigue, and also acute pancreatitis, which is the most common complication that we see. Next slide. So I'm going to skip details of lipid metabolism, but to keep it simple, essentially what happens in the condition is that when you are ingesting fats in our body, fats are meant to be used as energy sources. They're broken down and sometimes they're reformed, and basically are the fats at the simplest level would be broken down into triglycerides. And triglycerides, because they're not water soluble, they cannot just freely float around in the blood, need to be carried by what I really like this analogy, a vehicle that carries it around, a type of lipoprotein, which is chylomicrons, because chylomicrons are a combination of basically fat and protein that can help carry this fat around in our blood. So different places in our body, whether it's our muscles or somewhere else, wherever you need fat source as an energy source, can be used. Next slide. So chylomicrons, when they're floating around in our blood, are basically broken down for energy via this enzyme that we call, this a key one, lipoprotein lipase. I just want to take a moment to talk about just lipoprotein lipase, because I know sometimes there can be a lot of confusion, because so this is a very specific enzyme, lipoprotein lipase, because there's about 10 enzymes that are lipases in our body. There's a hepatic lipase, there's a pancreatic lipase, there's a lingual lipase, and in FCS, those lipases are not affected. We are not concerned about those lipases. We are concerned about specifically lipoprotein lipase. And this is something that's usually, it's expressed in the endothelial cells in our blood vessels. And the job of this lipoprotein lipase usually is to make sure that it can derive that triglyceride and break it down and give it to our muscles and everywhere else and use it as an energy source. Next slide. And then what happens is that in FCS, the LPL that we're looking at, the lipoprotein lipase that's supposed to do that job, it's either not working properly or it's not really there at all. Essentially, our instructions in our DNA that make RNA and eventually give rise to a protein called lipoprotein lipase are not working properly. And when they don't work properly, you get a buildup of these fat-carrying chylomicrons in our blood. Usually when an individual who doesn't have a disease state like FCS can clear chylomicrons within about 15 minutes into a maximum of about 2 hours, all chylomicrons in the blood are cleared up because they get used up or they're stored in different places in the body. But what happens in FCS is that because your LPL is not working, these chylomicrons are just staying in the blood, which is what gives the blood its whitish, pinky white sort of appearance that we typically see in patients with FCS. And that can sometimes be actually quite diagnostic when somebody is looking at that blood, because it's very distinctly different from normal looking plasma. And then next slide. And as a result of these chylomicrons being built up in the blood and just floating around, these can basically clog up in different places in our body, including the pancreas very commonly, which causes inflammation in the pancreas and can trigger pancreatitis. And our pancreas is a very essential organ. And in some people who have recurrent pancreatitis, that's all they might get. But in other people who have several episodes of pancreatitis can sometimes develop complications like chronic pancreatitis or pancreatic insufficiency, or basically diabetes essentially as well. So it's very important that we are trying to keep those chylomicron levels low in our blood. And the way to do that is by, at the moment, the only way to do that, if you're in North America, is to restrict to a very, very restricted diet that keeps it less than 20 grams a day, such that if there are no fats in your blood, therefore they will not build up if you're not ingesting them in your diet to begin with, because they have nowhere else to go, because the system that's supposed to clear them is not clearing them up. Yeah, and now I think we're going to pass on the slides to my colleague Susan Toomey, who's going to talk to us about genetics of FCS.
Thanks. Hi, I'm Susan Toomey. I am one of the medical science liaisons at Ambry Genetics. And I'm going to jump right into, we can go to the next slide, thank you, into a brief overview of genetics and how it relates to FCS. So you guys are getting a lot of science this evening. I promise this is my only heavy science slide. So our bodies are made up of trillions of cells, and each one of those cells contains the genetic material that tells the body how to grow, how to work, how to function. And I like to think of a basket. And within that basket are all these bundles of yarn. So those bundles of yarn, think of those as chromosomes. And you can see in that picture, the little, on the left-hand side, you've got the big round cell, and next to it, you have the chromosome. So if you think of that as the bundle of yarn, the DNA is actually the single string of yarn. And then we can think further of a mutation as a little snag in that string. And so when you're using that bundle of yarn, that little snag on that string might cause all kinds of problems when you're knitting and using that yarn, but it might not at all. And that's kind of what mutations do. Sometimes they are pathogenic, where they cause problems, they might cause disease, and sometimes we can get a snag or a mutation and it's completely benign. So we have to kind of sort through that. Now, on the right side, I wanted to talk a little bit about how FCS is inherited. And it is called a recessive condition. It's, if you look at the diagram on the right, I'm showing you how that works. All of these genes that I talked about on our chromosomes come in pairs. We've got one from our mom and one from our dad. So there's two copies of each gene. And if you look at this family that's pictured here, each parent that's pictured is a carrier of FCS. And we know that because they have one little white square at the bottom of one of their chromosomes that's representing a normal functioning gene, and then a little blue square on the other chromosome, which is representing a gene that has a variation or mutation. We call it lots of different things, but what it means is basically it's a snag in the string of yarn. So recessive inheritance means that to be affected with a condition, the individual has inherited two copies of the gene that have mutations. So in this picture, the child on the bottom, on the far right, has inherited two mutations, two blue squares from the parents, which means that child would be affected. The two in the middle are carriers like their parents. And the child on the far left has inherited the two not normal copies. And so the way that things typically work in genetics is that family members that are carriers wouldn't have the condition that they're carriers for. So in this case, FCS. But because genetics isn't always as straightforward as we want it to be, we know that in this condition, sometimes the carriers can actually have some of the health issues that might be similar to those individuals with FCS, maybe a little more on the mild side, but they might have elevated triglycerides. The other possibility is that a carrier looks like a carrier, but because we only have found one little blue mutation on one of their chromosomes, but we don't yet have enough of the scientific knowledge because we're always learning in this field. We don't have enough knowledge yet that we need to make sure that what looks to be a normal gene on the other chromosome doesn't in fact have something going on that we might not yet recognize and know about. So there's also the possibility in genetics of having uncertain results. And that's where genetic counseling comes in and is incredibly important. And we'll be hearing about that in more detail with the next presenter. So we can go on to the next slide. Oh, thank you. Okay, so there's lots of benefits of genetic testing, and here are just a few of them. In FCS, it's going to get you an accurate and possibly an early diagnosis if we do this early on. If a test is positive, it can identify the disease-causing variants or mutations, and that can confirm the diagnosis in someone who's had a suspected clinical diagnosis for a while. It can also inform treatment. So when a diagnosis is confirmed through genetics, that might trigger referrals to specialists, might trigger some lifestyle modifications, medications, and therapy recommendations as well. And then the thing that I think is incredibly important about genetic testing is increasing family awareness. So having a genetic diagnosis allows for those conversations that family members can have with each other, with the other family members that might be at risk but might not know it. So knowing the exact variant through genetic testing makes family testing more straightforward. And since FCS is very rare and inherited, a previous family history of FCS might be absent at the very beginning. There's also limitations to testing that I think are important to point out, and I kind of alluded to that on the previous slide. And that is that while we know a lot about the genes that cause FCS, there's always more to learn. And genetic testing can provide a negative result, a positive result, or at times an uncertain result. And when a patient receives an uncertain or negative result, it does not absolutely mean that there isn't a genetic cause to the condition. It might be that we haven't been able to find it based on the level of scientific knowledge that we have today. Okay, next slide. Great. All right. So in case you guys didn't know, Ambry Genetics partnered with Arrowhead Pharmaceuticals to provide no-cost genetic testing that also includes no-cost genetic counseling with that same program. So the website is listed at the top here in blue, and I can put it in the chat after my portion is done. And when you go there, you're going to find all the information about how the testing program works. We also have this flyer that's on the left that I can make sure is available to you all as well. If we could go to the next two, one more click. There we go, sorry. So these are screenshots from our website. And when you scroll through the website, you're going to learn all about the testing program, but you are going to see that there are some eligibility. And the eligibility criteria is on this slide. So to qualify for the no-cost testing, patient must be 17 years of age, have a fasting triglyceride level of over 750, and can't have had prior genetic testing for FCS. And if the patient qualifies, then we do a genetic panel of the 6 genes that you see listed here. And if you're curious, and it makes a lot of sense from what we've learned so far, that LPL is the most common gene associated with FCS. All right, next slide. Okay, so if you keep scrolling on our website, you're going to get at the bottom the information down here that you see for how the program works. And there are 2 ways that patients can get tested through this program. The first way is through a healthcare provider. So the patient can see their doctor. The doctor can use the steps that are outlined here on our website to order a test kit, collect the sample, and receive the results. And genetic counseling, as I said, is included along the way in that process. But if you see a little bit lower, there's also another route to get tested, and this is patient directed. So patients can go directly to this website, scroll down, and where I've highlighted in yellow, it says get started. The patient themselves can get started with the process. This is going to link them up to a page where they connect with a genetic counseling session, and that gets the testing process rolling. Now, a lot of people want to know, well, what type of sample is it? Because that can be a big concern. And we have 3 different types of actual specimens that are all the same in our laboratory, and we'll accept any of them. So that little picture on the right has the different specimen types. The little purple tube, that's a blood tube. We can have a blood sample. The middle one is a little cheek swab, and that's a really good testing method for someone who's not, that might be hard to draw blood from, not interested in having a blood draw, and maybe cannot produce enough saliva. It's a good testing type for kids, to be quite honest. And then the tube on the far right is a saliva tube. You may have seen those before. It's a very common saliva tube that's used for 23andMe, Ancestry. Most genetic testing companies use the same exact tube, and you just spit in it, close up the cap, shake it up, and send it in. So it's super easy. Don't have to get a blood draw, and all of those tests have the same accuracy. So with that, I think that what we're going to talk about next is the actual genetic counseling. And Ashley will be joining us to talk about that process. Hi, Ashley.
Hi, thank you, Susan. Yes, my name is Ashley Parrott. I'm a genetic counselor, and I work with a company called Genome Medical, who works in partnership with Ambry and Arrowhead Pharmaceuticals related to the genetic testing program that you just heard about. So I'm going to provide just a general overview about what genetic counseling is, who genetic counselors are. Genetic counselors are advanced trained medical professionals who have training in the areas of human genetics and counseling techniques. They have specific training and experience to help individuals and families make decisions regarding their genetic health and help ensure that each individual is receiving the right test at the right time for them. Genetic counselors can help guide a person and their family through the genetic testing process. And genetic counseling itself can be thought of as the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to disease. Next slide. So genetic counselors really can have kind of different roles, and these different roles kind of may come in patient to patient, but genetic counselors can also sort of play different roles on different medical teams. So this can vary somewhat, medical office to office. Generally, genetic counselors can provide information about how hereditary genetic conditions may be affecting an individual or their family. can help discuss best testing options for an individual, as well as the process of testing and review of possible test results as testing is being arranged. Genetic counselors can help with medical decision making, whether that be, decisions about having a genetic test, or when results are available, decisions about kind of next steps, where to go from there based on test results. When genetic test results are available, sorry, genetic counselors can help explain those results, really try to personalize kind of conversations to tailor, discussion about what an individual test result means for a person and their family. It can discuss kind of information about diagnosis based on a test result, family risk assessment based on a test result. And with the last point on this slide, we'll just kind of point out that there's a website available for the National Society of Genetic Counselors that provides some additional information about who genetic counselors are, what they do, but also offers a search tool, a way to kind of look and find a genetic counselor kind of local to a specific area, as well as locating genetic counselors who provide like telehealth virtual genetic services. And with the next couple of slides, just wanting to share some information about what genetic counseling visits really look like. What can we expect with genetic counseling? A few points, I think, just kind of some general facts, pieces of information that may be helpful for individuals to know going into a genetic counseling visit. And an important piece, I think, is that genetic counseling really is intended to be a discussion, an interactive discussion with an individual and or their family, as opposed to, a healthcare provider just kind of regurgitating a list or a checklist of information and recommendations. So with genetic counseling, there really is a goal to tailor information discussed to the wants, the needs, the goals of an individual and their family, understanding that these needs and goals are going to be different and variable family to family. We'll share that I think with many rare conditions, including FCS, I think we all probably understand that it can be difficult locating a provider with familiarity on the condition. With genetic counselors, genetic healthcare providers in general, these providers really are used to and accustomed to dealing with rare disease, rare conditions. And so even for, some genetics healthcare providers who may not have a ton of experience with FCS, may not see this, often in their practice, genetic counselors are going to know how to access the right resources, how to locate appropriate testing resources, recommendations for kind of next steps based on results, because they are used to dealing with rare diagnoses. A main goal with genetic counseling, I think, really is in helping translate complex genetic information to information and test results themselves to information that is usable and informative for an individual family. So that will include, interpreting individual test results, as Susan mentioned, were results negative, positive, uncertain, and really kind of tailoring that conversation to what a specific individual was found to have with genetic testing and what that then means for them and their family. An important piece I'll make as well here is that I would want, individuals, patients, healthcare providers to also know that genetic counseling does not always equal genetic testing. Some families are in more of a phase where they're considering a possible test, but are unsure if, based on their history of testing, is really appropriate or indicated for them. are unsure for various reasons if they want genetic testing. And, but part of what really can be discussed with genetic counseling for some individuals is really helping make that decision about, is genetic testing right for me right now? Is it right or indicated for my family? Next slide. And I'll share, I'm not going to kind of walk through each of the bullets on this slide, but wanted to provide a general overview on kind of what we can expect, before, during, after a genetic counseling appointment, what those types of visits really look like. A good portion of a genetic counseling visit and discussion with a family will include review of medical history, family history information. So for patients, it's a really good thing, as much as possible for patients to do kind of a good review of gathering their, personal lipid screening results, test results not only kind of from more recent screening, but kind of older screening as well, to sort of have some comparisons. Gather family information. Are there family members with similar diagnoses or symptoms? Having that information to share with the genetic counselor before a visit, if possible, is really helpful, but having it on hand to discuss and really be able to review in a detailed way can make genetic counseling visits, even more informative. During a genetic counseling visit, that history information will then help guide discussion about, risk assessment. Does FCS seem to be a condition that could be impacting your family? If so, what are the genetic testing options? During a visit, a genetic counselor will help really review the nuts and bolts of the process, the logistics. How do we get this testing done for you where you are? As well as coming up with a good game plan for how those results will then be shared, how genetic test results, documentation, summary information will be shared with an individual in a usable way. Commonly, that will include, providing actual copies of genetic test results back to families, their healthcare providers, as well as providing more kind of written summary or letter information that helps kind of with more of that translation about, making those test results usable. What do these results mean for me? What are my next steps with medical care? What do I need to tell family members? Who in my family needs to be informed about this? What should I be communicating about level of risk for other family members? That will all be a part of, what genetic counselors will be thinking about and discussing with an individual. Next slide. And from here, I'm going to turn it back over to Fisa for some additional conversation with FCS.
Hi everyone, I'm back. So after all that great information, that's actually so helpful to know about the premise of why anybody would really even need genetic testing or the utility of having genetic counseling. We can apply it now to FCS itself. So far, we understand what the disorder does, but from a genetic point of view, essentially, although we can appreciate how difficult it is to live with FCS. From a genetic testing point of view, FCS is actually a really good disorder to diagnose because it's a single gene disorder, meaning that we know the genes that actually cause it, and they're generally caused by single genes. We know 90% of cases with FCS are actually caused by mutations in the LPL gene. And as Susan went over in a really comprehensive way, what genes are basically just instructions that give us downstream the protein that is missing. But we do know that there are other genes as well that can cause FCS that are not limited to LPL. And I actually heard a very good analogy today. If LPL, the lipoprotein lipase, is the vacuum that's supposed to clean up all the chylomicrons out of the blood, there are other parts that make the vacuum actually work. And those other parts or proteins are made by instructions from genes in ApoC2, ApoA5, LMF1, and GP1, HBP1 that you can see on the screen are so these in total are the primarily 5 genes that we know that we can test for to know if you have variants in those genes that could give you rise to the disorder itself. And essentially, we know that the prevalence of these kind of mutations in the population depends on where you are. In places like Quebec in Canada, that prevalence tends to be higher. So it could be anywhere from 1 in 100,000 to some places where the prevalence is about 1 in a million. And genetic testing can help us figure out whether you have that variant and can actually confirm whether you have FCS or not. Next screen, please. So the mainstays of diagnosis as it stands, generally what happens is in a lot depending on where you live, people get diagnosed in infancy. Sometimes in the UK, there's a heel prick test. In North America, we also do testing in infants when they're born that can diagnose metabolic disorders like FCS. But if it does not get diagnosed at that time or gets missed, what happens is people present with triglyceride levels higher than 10 millimole per liter, or if you are in the States, you probably use milligram per deciliter. 885 is the sort of the minimum that we're looking at. But most patients that I know of and that we see in clinical practice are about 20 to 25 or higher millimole per liter without having pancreatitis. Generally is where they are at. And then obviously when the levels get even higher than that, then they start to get symptoms of nausea and vomiting and abdominal pain, and that some of you might also be familiar with, which can be very excruciating. And in infancy, you can also see, children who are not gaining weight, or which we refer to as failure to thrive. And then the second mainstay of diagnosis, which has sort of become the gold standard now. So before genetic testing actually came along, we used to check post-heparin activity of LPL itself to determine whether somebody had FCS or not. That's not commonly used. It was also not the most reliable way to check whether it was FCS or not, but that was before genetic testing was so widely available. But now that we do have genetic testing, we're able to test through actually really fast and wonderful methods of sequencing to determine whether you have genetic mutations in your LPL or other regulatory genes for LPL as well that can diagnose FCS. Next screen, please. So we're just going to switch gears a little bit. I'm trying to be fast now because we want to get to questions as well. But just give me about 10 minutes here because I don't want to rush through some of this important conversation about clinical research. So essentially, the options are very limited when it comes to rare disease. And in some way, we should be hopeful because there are things that are being studied that are sort of in the pipeline right now that we're excited about to see. So one of the ways that we can get access to some of these medications or these novel treatments that are still under study is through clinical research. And clinical research is essentially done, obviously, to add to a medical topic. The purpose of clinical research or clinical trials is not to treat patients, it's to see whether whatever we are testing does what it's supposed to do, and whether it does it better than the products that we already, or the drugs that we already have in the market to treat a condition. There are two main types of clinical research that we look at. There's observational studies where you're being studied, but we're not actively giving you any intervention ourselves. We're just observing how things happen naturally. And then clinical trials are essentially, you're looking at, depending on the phase of the clinical trial that you're enrolled in, you may or may not be given the intervention, but the purpose is to very clearly study an intervention and its impact. So clinical trials usually study new treatments to determine safety and efficacy in humans, and they're divided into different phases. Next slide. Yeah, so just to summarize, so clinical trials can compare a new medication to either a placebo. A placebo is basically our control, which is usually giving nothing, or in a blinded or randomized control trial. If you've heard that, the control arm is referring to you wouldn't necessarily know that whether you're getting the medication or not, because we were trying to keep you blinded to the study, meaning that we don't in any way want to impact whether we think something works or not on the results. And that sort of is the purpose of a placebo. And essentially, one of the ways you can see which clinical trials are actively out there is clinicaltrials.gov is a pretty good website that where international trials are actually registered. And you can see trials that are happening all over the world. A lot of them are happening in USA, UK, Australia, and even if the primary studies are somewhere else, they recruit participants in other countries to make those trials happen, especially for rare diseases, because it's so difficult to find patients. Next slide. And some of you might be wondering, when you've seen clinical trials, what each of those phases are. So phase 1 of a clinical trial, actually before we even get to human trials, usually there's preclinical trials that are done where we look at the function of the drug and its and how it sort of works in animal studies before it gets to clinical trials. And then in phase 1, we have a very small number of people who get a very minimal dosage of the drug, where we're trying to figure out whether this particular medication is safe to give or not. And in phase 2, we're trying to figure out which particular dosage is going to have an efficacious effect on the people, and actually providing some sort of benefit, if it is providing that benefit, and also we continue to monitor safety. So phase 1 and 2 are usually you're only given the intervention. Phase 1 and 2 do not have a placebo or a control, because we're very closely trying to study whether this drug is safe to give and at which dosage. Phase 3 is where we have the randomized control trial, where we do get most of the patients, where we divide them up into the intervention group and the group that gets the control, which means nothing, to compare whether this medication does what it's supposed to do, at what dosage it works, and we're trying to see rare side effects. And basically, if it, and in all ways, we can monitor if this particular medication is better than what's already on the market or compared to other alternatives, what we have studied. Once a phase 3 drug is passed, generally it goes to the FDA for approval, and phase 4 happens after a drug has been approved by their regulatory authorities in respective countries. And then we continue to study what basically it's called post-market research, where we continue to study whether there's more side effects or risks that come up after. Next slide. So the other aspect that we just wanted to briefly touch on is that we've gone through a lot of things today, and as somebody who may be having a new diagnosis, or somebody who might have had the diagnosis for a while, there are certain care providers who should be a part of your circle of care that we recommend. And the first one, what I think would be definitely the most important one, I think, to me, is a lipid specialist or an endocrinologist, who can really closely monitor your lipids and can recommend therapies to treat it, as well as complications that occur with it, such as diabetes, that can be managed. And a lipid specialist or an endocrinologist can really manage that long term. And then equally important would be a general primary care physician, whether it's your family physician or whoever your primary care person is, who can sort of liaison and have all of your medications in one place and can monitor all of your health problems, and a registered dietitian who can help you, guide you through the different kinds of diets that you can have and to maximize the amount of nutrients that you're getting and keeping it within less than 20 grams of fat a day. The other ones listed here, a geneticist can definitely help you with not only diagnosis, but also genetic counseling and planning. If you're planning to have children and that is something that you're interested in, geneticists can really help you figure out and navigate a genetic diagnosis, as we heard earlier, and connect you to resources, the best resources that you would need for support after a diagnosis. And cardiologists, GI specialists, and hematologists can be closely involved in FCS care as well, depending on your needs and what other associated conditions you may or may not have if you have FCS. Next slide. So essentially, we've gone over a few things. We wanted to talk about diet a little bit as well. I will take just a couple of minutes just to briefly talk about diet, because diet is the mainstay treatment for FCS, the way it stands. And the important thing with keeping less than 20 grams of fat a day is to realize that that you may not necessarily be getting enough essential fatty acids that are basically we have to get them from food because our bodies do not produce them. You might not be getting enough fat soluble vitamins, so it's important that you are supplementing with vitamin A, D, E, K. If depending on a daily supplement might be definitely recommended, a multivitamin of sorts, just to fill those nutrient deficiencies. And you can derive a lot of your diet from low fat or lean protein rather than focusing on carbs. And that's the other one of the reasons why that plays a role in development of diabetes in patients with FCS, is a long-term diet of being on sugars and carbs can also play a role in insulin resistance and therefore diabetes. So you do want to focus on low fat or lean proteins like turkey or chicken breast if you do eat meat, or egg whites, tuna, whitefish, fat-free cottage cheese, skimmed milk. Those are just shrimps. Those are some of the options that you can refer to for low fat or lean proteins. And in terms of carbs, you really want to focus on complex carbs, not simple carbs. When we say complex carbs, that's referring to brown rice, or if you, depending on you have to calculate, depending on the fat level, you may be able to have whole wheat pasta, couscous, or oats, or a shredded wheat cereal are some options. And lastly, if you are eating out, definitely looking into the menu beforehand, and if you do take MCT oil, taking the MCT oil supplement with you would be a very good option. And if you're cooking, I know because I do this every day. I'm the cook in the house, and when I'm cooking for my husband, sometimes I'm very frustrated with not being able to use oil because everything sticks. So when you don't want to use oil, you can use a lot of vegetable stock, water, vinegar, love soy sauce. There's a lot of oil-free options that can keep your dishes still tasting good, that you can still use. And I think investing in definitely a good non-stick PFOA free pan would be a really good one to consider. And there's actually a very good resource. There was a very good lecture earlier this year last year that was hosted by SOBI, by Dr. Paolo Perini, who gave a lecture on FCS genetics, as well as there's a very good basically YouTube lecture that was basically based on the presentation. I'm throwing the link here as well, by dietitian Sarah Fisherman, who is actually a registered dietitian for adult metabolic disorders. So this is her area of expertise, and you can refer to actually her presentation if you want to know a little bit more about diet. And there is, I was actually going to, maybe I can still share my screen quickly. I'm not sure, it's not actually giving me an option, but there's a link right there that's referring to that. I really like this. It's actually a scientific article, but it's a scientific article on dietary recommendations throughout life for patients with FCS. And it's a very good resource to refer to. And it even gives you a meal plan for what your lunch might look like, what your breakfast might look like, and supplementation with MCT oil. That resource is also in the chat box now that you can refer to. And I think having living with this condition can obviously affect people in many different ways. Having support around you is very important. And I think being part of Action FCS, which is based in the UK, being part of Living with FCS, it's based in North America, as well as different support groups that you're able to find, can be really helpful and can make you feel less alone. Because I can only imagine what it's like to live with a rare condition. So finding those supports is highly recommended. And that is it for a presentation. And I think the next slide, yes, this is my lovely husband with FCS, and I've sort of, I guess, shared what our life looks like, and we can now move on to questions if anyone has any. Thank you so much for having us.
That was an incredible presentation. We do have a few questions from our audience, our viewers, and I tried to consolidate them into the order in which you presented. So Susan, there was a question, sort of a multiple question. How long does genetic testing typically take? And when could a person expect to receive the results, and then what do they do with those results?
Yeah, those are great questions. So when I started in this field, genetic testing, and this is not an exaggeration, it took 6 months. We had a very difficult time sequencing genes and finding mutations and knowing what we were looking at. Right now, we can do this type of test anywhere between 10 days and 21 days. It depends on the laboratory. It depends on what test exactly you're having done. But one thing I will tell you is that the amount of time, if a laboratory says it's going to take us 1 to 3 weeks, just because you get your result back at 1 week or you don't get it back till 3 weeks doesn't mean that they have found something or not found something. Sometimes the laboratory sees something that they've never seen before, a mutation that they need to really work through, and it might end up being benign and the report is still normal. So having a longer length doesn't mean really anything. It's just a variation and just speaks to how complicated the tests are to do in the laboratory. What to do with those results? That's the phase that maybe Ashley can add a little bit to, because that's when you need genetic counseling to help work through those results.
Yeah, and I'll add that I think that what to do next part is going to be very variable depending on kind of where a patient is in their medical journey. For some individuals, they may have a long-standing diagnosis, are already being treated and managed as if they have FCS. The testing may be more kind of indicated in helping with family risk assessment. So the what comes next piece may be more of a focused conversation on what testing can we offer to family members, which family members are appropriate to target for genetic testing. For some individuals, the test results themselves really may be playing a big part in new diagnosis or new understanding about possible options, consultation with a dietitian, getting back in touch with, their lipid specialist, their endocrinologist, and talking more about kind of a detailed day in, day out medical plan for them. And if that's the case, the kind of whatever provider you're working with to help order that genetic testing, talk about the results, can really help guide then which specialist do we need to go to next? What is the next step for you based on where you're at in your own kind of medical diagnosis journey?
Very good. So another question came up. It's a little bit more specific, but if a person has, say, I have FCS and it's confirmed through genetic testing, but my spouse does not, is it correct that my children will definitely be carriers, or is that a little bit up in the air? Susan, I think you covered this a little bit, but if you could just, oh, hold on. We just need your,
Sorry, I had turned my mic off. I did cover it, but I didn't cover this specific scenario. So the photo that I showed had each parent being a carrier, but this is different. This is talking about one parent having two mutations, so a mutation on both genes, and the other parent not having. And now the only way we know for sure that that other parent doesn't have any is if they've been tested. We can't know for sure. They might be a carrier. We're assuming they're not a carrier or they're not affected if they don't have signs or symptoms of FCS. But unless they've actually had genetic testing, we don't know for sure. But in this scenario, we'll assume that we know that that individual does not have any mutations and this does. In that instance, yes, each child would be a carrier because they would receive one blue square, if you remember my picture, from the parent who has FCS, and one white square from the parent who does not, because that's all those individual parents can contribute to the child. So each child's going to get the blue from the one parent and the white from the other parent and be a carrier.
very good. Thank you for that information.
Yep.
And Fizza, maybe another question came in, and maybe from a medical perspective, you could let us know. So potentially there is an embryo or any other stage of gestation where the person with FCS, the mother, is has been diagnosed with FCS, the parent hasn't. Could that embryo, or is there a stage of gestation where the testing could be done, or if it's done currently?
Hey, thank you for the question. Yes, there is definitely genetic testing that can be done in embryo. And like I said, because FCS is a single gene disorder, it's actually a good one to test for, and we are able to test for it. In terms of when if you are going through, I'm just giving one scenario, if you are going through in vitro fertilization, you can actually do pre-implantation genetic diagnosis before the embryo is even implanted to see whether that genetic mutation exists in that embryo. Obviously, there is a whole bunch of other ethics and things that you have to consider, the pros and cons of doing that, and how that will impact you as a person, your family as a person, and what sort of is your goal of doing it. And I think I just want to preface that question just in general. When it comes to embryonic genetic testing, you really do want to have those questions in mind before you go ahead and do it, and which is where genetic counselors are great to have this conversation, because they can tell you whether, because there's a lot of emotions and feelings that are involved with having that kind of testing done. And then you also want to know what you want to do with those results. So you want to know that beforehand. In terms of embryo that a woman is carrying, there is 2 genetic tests that are done at different stages of gestation. CVS in Canada is usually done between 10 and 13 weeks, but I'm pretty sure it can be done between 11 and 14 weeks. where we can look at genetic disorders. And then the second one is immunocentesis, which is usually done at, I think it's 15 to 20 weeks of gestation. That can also look at gene disorders. One is more accurate than the other, but there's also different risks that are associated between CVS and immunocentesis. And this again is a conversation you would have with both an geneticist as well as an OBGYN to determine what would be the best for you, because especially in pregnancy, if the pregnant individual is the one who has FCS, you have a lot of other things to consider as well that might be complicating your pregnancy. And some of these genetic tests might not be the best option for you. So that's again, a conversation you want to have with your primary care provider, but those are options that exist to test for FCS at the embryonic stage.
Yeah, and Amber, I'll add that as a previous genetic counselor myself, and Ashley's a genetic counselor, I was a genetic counselor in an infertility clinic and prenatal for many, many years. And those are the conversations that genetic counselors are best equipped to handle. And so if those come up, you might have genetic counseling at time of diagnosis. You might have genetic counseling again later when you're ready to start a family. And those conversations can look different depending on what time you're having the genetic counseling.
Very good, very good. Well, thank you all. In being respectful of everyone's time, certainly on behalf of the board of the FCS Foundation, thank you all for participating, and a special thank you to Fiza Javed, who is on our medical advisory board, Ashley Parrott, who is with Genome Medical, and Susan Tomey, who's with Ambry Genetics. And thank you all very much. We appreciate your participation and wish you a very good day.
Thank you so much, everyone.